चलो, starting with the first question, guys, and it says a female who delivered spontaneously had a history of blood transfusion. Most important keyword for you after delivery, and there is a failure to lactate now. Now presents with amenorrhea. Amenorrhea is absence of menses. ठीक है? Now presents with amenorrhea, that is absence of menses. There is no history of weight loss. There is no history of sepsis as such. Sepsis is nothing else but infection itself. ठीक है? So what is the diagnosis now? So what are you suspecting over here? So please remember here, after a history of spontaneous delivery, spontaneous, that means a normal vaginal delivery, the patient needed a blood transfusion. Why she needed a blood transfusion? क्या हुआ होगा? क्या हुआ होगा? There would have been a lot of bleeding after delivery, and any bleed after delivery is considered as BPH. So therefore, the history of blood transfusion, that is suggestive of postpartum hemorrhage in the female. समझ गए? ये जो हिस्ट्री बता रहे हैं ना ब्लड ट्रांसफ्यूजन की, that was due to postpartum hemorrhage, due to which she required a blood transfusion. ठीक है? Now what are they saying? The female is having failure to lactate. So usually after delivery, the lactational period starts. मतलब the patient or the female starts producing milk due to the action of which hormone? Due to the action of prolactin. ठीक है? So definitely, and now she presents with amenorrhea. So definitely during this lactational period, okay, during this lactational period, when there is increased amount of prolactin in the body, patient, does she have menses? Menses होते हैं क्या lactation में? नहीं होते. Okay, why there is no menses during lactation? That was a question previously. Because lactation में कौन सा hormone predominant होता है? Which hormone is responsible for milk synthesis? The hormone which is responsible for milk production or milk synthesis is known as prolactin. The funda of prolactin is, please remember, prolactin will inhibit. Prolactin is an inhibitor, physiological inhibitor of LH and FSH. That means it will inhibit the gonadotropins, that is your LH and FSH. That is the reason why when during the lactation period, the levels of prolactin are high, there would be low levels of LH and FSH. FSH will stimulate the ovaries and it will stimulate the follicular growth. FSH क्या करता है? This is the basic funda. I hope all of you are quite aware now. FSH will stimulate the ovaries and it will lead to follicular growth, whereas LH will stimulate the ovaries. That means the corpus luteum, and it will lead to synthesis of progesterone. So FSH की वजह से किसका secretion होता है? This is the basic funda, guys. एक बार ये मुझे नहीं चाहिए कि that you should have any confusion. सबसे पहले hypothalamus is the master of the master gland. It secretes what? It secretes GnRH, gonadotropin releasing hormone. It stimulates the anterior pituitary, and your anterior pituitary secretes what? It secretes the gonadotropins, that is your LH and FSH. Now this FSH will stimulate the ovaries. The LH will stimulate the ovaries. ठीक है? Or the gonads we can say, okay. FSH की वजह से किसका प्रोडक्शन होगा further? Estrogen. Whereas LH की वजह से progesterone. This is no issues with anybody. Estrogen is secreted by which cells of the follicle? Estrogen is secreted by which cells of the follicle? Granulosa cells. There are two cells in a follicle, the granulosa cells and the theca cells. ठीक है? So जो granulosa cells होते हैं, they are responsible for estrogen production. These are very basic physiology questions. No mistake should be done in that. अगर ये single one liner आता है तुम्हारे एग्जाम, ठीक है? Whereas progesterone is secreted by which cells? Progesterone is secreted by the corpus luteum. Okay, progesterone is secreted by the corpus luteum. The luteal cells will secrete progesterone. No issues with anybody. ये basic समझ में आया? That's what I'm talking about. ठीक है? Now going back to our question again. यहाँ पे मैंने क्या बोला? So here the patient is having high levels of prolactin due to lactation, due to which the LH and FSH levels are low, and due to this reason, if FSH will not stimulate the ovaries, तो follicular growth होगी क्या? नहीं होगी. Follicular growth will not occur. ठीक है? If follicular growth will not occur, okay, estrogen production will occur or what? No, there would not be any. So there is decreased follicular growth. And if there is decreased follicular growth, what will happen? There is decreased amount of estrogen. And usually, if the estrogen reaches a peak, उसके बाद क्या होता है? Sudden. उसके बाद there is a LH peak. And उस LH peak, LH surge और LH peak की वजह से क्या होता है? There is ovulation. But यहाँ पे estrogen ही नहीं बढ़ रहा. तो अगर estrogen ही नहीं बढ़ रहा, तो LH बढ़ेगा क्या? नहीं बढ़ेगा. Any which ways LH is already low and estrogen is also not increasing. Therefore, patient में ovulation होगा क्या? Patient will have no ovulation. And therefore, अगर menses होंगे क्या? नहीं. So that is the reason why patient is having amenorrhea. That is the reason why, as the LH is also low and FSH is also low, finally it lands up the patient into amenorrhea. ठीक है? So this is what is called as a normal or a physiological amenorrhea, जो normally lactation में होता है. And this is the reason. Okay, this is the reason for a normal lactational amenorrhea. But here in this question, the patient does not only complain of failure. The patient does not only complain of amenorrhea. Okay, but the patient also complains of failure to lactate. If prolactin levels are high during lactation, okay, if prolactin levels are high during lactation, there would be increased milk production or decreased milk production? There would be increased milk production, right? There should be increased milk production. But तुम्हारी इस female patient में क्या दिख रहा है? She is having failure to lactate. That means she is having decreased milk production. Why she is having decreased milk production? Because there is low level of prolactin in her body. So here the cause of amenorrhea is not the normal or the physiological amenorrhea which occurs during the lactational period. क्योंकि इस patient में prolactin levels low है, prolactin levels high नहीं है. ठीक है? So as the levels of prolactin are also low, as the levels of LH and FSH are also low. All of these hormones are produced from which pituitary? All of these are hormones of the anterior pituitary gland. तो क्या लग रहा है? All the hormones of the anterior pituitary are decreased, and this condition is what is called as anybody? Hypopituitarism, right? First, hypopituitarism. Now, अगर hypopituitarism की बात करें, one option can be easily ruled out. Which one? Pituitary adenoma. Adenoma is a benign tumor arising from the pituitary gland. अगर tumor है, तो hormone production बढ़ेगा या घटेगा? Hormone production will definitely increase. Here the hormone production is decreased. So option D is ruled out. Now if I am talking about option A, why I am ruling out option A? Here the patient is not complaining of any hypothyroidism like features. There is no weight gain in the patient. Okay? There is no confusion or any neurological symptoms in the patient. Okay? There is no cold intolerance in the patient. There is no bradycardia in the patient. कोई symptoms दे रखे क्या? नहीं दे रहे थे. Here, rather, they are not talking about decreased levels of T3 and T4 or decreased levels of TSH. Rather, they are more likely talking about decreased levels of prolactin and decreased levels of gonadotropins. So that is the reason why I'll rule out option A. Now we are left with Sheehan syndrome and Simon's disease. Both of these conditions will lead to hypopituitarism. Both of these conditions can cause hypopituitarism. दोनों में cause भी same है. Both of these will lead to damage to the pituitary. In both the condition there is damage to the pituitary. In both the condition there is a damage to the pituitary gland. But in Simon's disease, what is the cause? In Simon's disease, the cause of hypopituitarism or the pituitary damage is either some malignancy or it is some infection or some inflammation. तो अगर कोई inflammation हुआ है, कोई CNS malignancy हुई है, कोई infection हुआ है like meningitis, then if there is damage to the pituitary gland, then the patient will be diagnosed as Simon's disease. But why we can easily rule out Simon's disease in this question? Because there is no history of weight loss. As there is no history of weight loss, you can rule out malignancy in this patient. Secondly, as there is no history of sepsis or any infection, so infection and inflammation is also ruled out. So both the causes which are required for Simon's disease are not present in this statement. So by the rule of exclusion, what should be your answer? Your answer should be Sheehan syndrome. Yes, all of you marked it right, I know that. But इसके पीछे का logic बताना जरूरी है, because other time if they give that the patient had a malignancy, you need to know that that can be Simon's disease in the patient. ठीक है? अगर वो meningitis की history लेते, then that can be Simon's disease. ठीक है? यहाँ पे Sheehan syndrome is what? Sheehan syndrome is a postpartum hypopituitarism. What is Sheehan? So please remember, Sheehan syndrome is nothing else but postpartum. Postpartum at the partum is nothing but the delivery. So after delivery, the patient is suffering from hypopituitarism, decrease in all the production of pituitary hormone. Okay. So Sheehan syndrome, where the patient is having postpartum hypopituitarism. No issues with this, anybody? That's the basic idea. Okay. What is the cause? Why after delivery the patient suffers from hypopituitarism? The reason is after delivery, the patient had a lot of blood loss. That is what is called as PPH. So after delivery, as the patient had a huge blood loss, that is postpartum hemorrhage, a lot of bleeding occurred after delivery. That has led to what? This will cause, if there is a lot of blood loss in the patient, that will land up the patient in shock. That will land up the patient in shock. And shock की वजह से क्या होगा? There would be decreased blood flow to all the organs of the body, right? There would be decreased blood flow to all the organs of the body. Just like that, there is also decreased blood flow to the pituitary gland. And decreased blood flow is what is called as ischemia. And if there is a prolonged ischemia, बहुत time तक अगर blood supply नहीं मिलता, what will happen? There would be necrosis or cell death. So here, the pituitary gland suffers from ischemic necrosis. Okay. So ischemic necrosis of the pituitary gland occurs, and that is the reason why the production of all hormones will go down. Okay, production of prolactin, production of gonadotropins like LH, FSH, even production of TSH will also go down. Everything will go down. So that is a classical case of Sheehan syndrome. The patient will have history of PPH that causes ischemic necrosis of pituitary gland. Therefore, Sheehan syndrome is also known as pituitary hypoplexy. That is another name used for Sheehan syndrome. The option में अगर पूछा जाए, it is also known as pituitary hypoplexy. That is decreased function of pituitary gland. Okay. So moving with the next question now. Question number 2. If I talk about the question number 2, क्या दिखा रहा है यहाँ पे? A 32-year-old pregnant female at 16 weeks of gestation presents to the OPD for antenatal checkup. Antenatal, natal, जैसे पार्टम डिलीवरी को बोला जाता है वैसे नेटल पीरियड भी डिलीवरी के पीरियड को बोला जाता है. सो antepartum is before delivery, postpartum is after delivery. So here the antenatal is before delivery, postnatal is after delivery. So she is coming for antenatal checkup, that means checkup during her pregnancy, and she gives history of previous 2 second trimester abortions. Okay, previous 2 second trimester abortion. Which among the following is done to rule out the cause of abortion in the above scenario? So now here they are giving that the patient is pregnant. She is at around 16 weeks of gestation. Okay, she is at around 16 weeks of gestation. Then she has come for antenatal checkup. Now she gives history of previous 2 second trimester abortions. Which among the following will be done to rule out the cause of abortion? So she was having abortions in which trimester, guys? Second trimester. So if I talk about abortions, first of all, what are abortions? Loss of the fetus. When? What is the criteria? Loss of the fetus before 28 weeks period of gestation. Q. Because 28 weeks is considered as the period of viability. That means in India, if a newborn is born at 28 weeks, then we can keep that newborn alive with the help of our healthcare facilities. If the child is born before 28 weeks, Indian healthcare facilities will not be helpful to keep that child alive. Okay? So that cutoff is what is called as period of viability. In US it is 20, in UK it is 22. Okay? So that's the important funda. For us it is 28. So any loss of fetus before 28 weeks period of gestation, or if the fetus is lost whose birth weight is less than 500 grams, or whose birth length is less than 35 centimeters. That is what is considered as an abortion. Okay? Now abortion. So as we were talking about this abortions, so first trimester abortions हो सकते हैं या second trimester abortions. We know now that the first trimester abortions are much more common. The cause for first trimester abortion, the most common cause for first trimester abortion is definitely chromosomal abnormalities. Okay? Chromosomal abnormalities. That means there can be a monosomy or a trisomy as well, okay, which can lead to loss of the fetus during the first trimester. Whereas the most common cause of abortions during the second trimester, it is the anatomical defects. It is usually the anatomical defects. Now here the patient has lost 2 fetuses, but in which trimester? second trimester. So it was more likely due to anatomical defects. So what we need to rule out? We need to rule out the cause. So we need to rule out the anatomical defects in the current pregnancy. We need to rule out any anatomical defects in the fetus in the current pregnancy. Okay. Now if I talk about option A, it is called as chorionic villus sampling, CVS. It is done at around what time? It is done at around 10 to 13 weeks. That is in the first trimester of pregnancy. Okay. It is done in 10 to 13 weeks in the first trimester of pregnancy usually. No issues with this. And that will help you detect what? जब chorionic villus sampling करते हो, then you will get a sample, and that sample you will send for karyotyping. That sample you will send for karyotyping. What does karyotyping help you with? Karyotyping क्या बताता है तुम्हें? Karyotyping will tell you the number of chromosomes, right? So if there was any chromosomal abnormality during the first trimester, then we would have gone for chorionic villus sampling. Any which way, it is not a first trimester abortion. First thing, 10 to 13 weeks time has surpassed already. And the third thing important, karyotyping is not required because here the cause is not likely to be chromosomal abnormality. So any which way, the option A is ruled out. Now, if I talk about a level 1 scan, level 1 scan is again done at around the same time in the first trimester. Okay, so level 1 scan is around again the 10 to 13 weeks, and it is done for what? It is called as the chorionicity scan. It is known as the chorionicity scan. So it is done for two reasons. Chorionicity scan is done for two reasons. First, to check the implantation of the placenta. कि placenta की actual location है क्या? कौन से type का placenta है? Twin pregnancy है या नहीं? ये सब देखने के लिए जो पहला scan करा जाता है, ultrasound scan, that is what is called as a level 1 scan, which is done in the first trimester around 10 to 13 weeks. ठीक है? So it will help you check the location of the placenta, any twin pregnancy if it is there. ठीक है? And the third most important thing, it will tell you about only one anatomical defect, which is the earliest anatomical defect which can be detected in the first trimester with the help of a level 1 scan. बताओ. अरे previous year question है तुम्हारे एग्जाम का. Level 1 scan can only detect one anatomical defect. Anatomical defect as early as this defect is detected as early as 10 weeks period of gestation. The only anatomical defect which can be detected in the first trimester with the level 1 scan is anencephaly. The question was, anencephaly can be detected earliest at, it can be detected earliest at the span of 10 weeks period of gestation. Nobody should forget this. Please remember this. No issues with this, anybody? That's the most important thing. Anencephaly matlab his cranial vault and his brain is not formed at all. Okay? That's the important thing. So any which ways, 10 to 13 weeks time has surpassed. So chorionicity or level 1 scan can also not be done. And any which ways, we need to rule out all the other anatomical defects. हमें बस anencephaly थोड़ी देखना है. And if a patient was suffering from anencephaly, usually the loss of fetus occurs in the first trimester. यहाँ पे abortions कब हो रहे थे? In the second trimester. So anencephaly, if it was there, then it would have caused loss in the first trimester itself. ठीक है? यहाँ पे again this can be ruled out. We are left with level 2 scan and amniocentesis. What has to be done, anybody? Now, please tell me, here we need to check for anatomical defect. Amniocentesis is again what? We will take a sample of the amniotic fluid. And once we take the sample of the amniotic fluid, again we will send it to the lab for karyotyping. So it will tell you about again trisomy or monosomy. Will it tell you about anatomical defects? No. And second thing, chalo, it can tell you about any monosomy or trisomy, and then you can suspect, okay, chalo, Down syndrome में तो ये anatomical defect हो सकता है. But the problem is, it is a very indirect procedure. And second, over here, it is an invasive procedure. Always we will prefer a non-invasive procedure over an invasive procedure, because with amniocentesis and with chorionic villus sampling, I hope now the audio is fine. So, with amniocentesis or with chorionic villus sampling, as it is a invasive procedure, क्या हो सकता है? There can be a risk of abortion. There can be a risk of miscarriage, right? Because see over here, this first procedure क्या लग रही है? What is this first procedure? ये image आ सकती है. Already images आ चुकी है. They have asked what is the below given procedure. What is this? Very good. So here you can see a needle is injected into the amniotic sac of this, and in amniotic sac, what is collected over here? Amniotic fluid is collected for sampling. ठीक है? And that amniotic fluid would be sent for the laboratory investigation. कोई दिक्कत नहीं है. So if amniotic fluid is collected for sample, this procedure is what is known as amniocentesis. Definitely ultrasound probe would be used. अंधाधुंध नहीं जाओगे तुम, ठीक है? So that is the reason. But here you can see, if you are creating a hole in the amniotic sac, will it not lead to rupture of the amniotic membrane at times? Will there not be any risk of loss of the fetus? Yes, there would be, right? So it is an invasive procedure and it has some risk of abortion as well. Next one, what is this procedure, anybody? Very good. So this is what is a chorionic villus sampling. क्या दिख रहा है? Here we are actually injecting a catheter, okay, via the vagina of this patient, and from there we are actually taking this catheter to the placenta. And what is present inside the placenta? In placenta there are villi. Placenta is also known as chorion. So the villi of the placenta are called as chorionic villi. ठीक है, तो उनमें से अगर सैम्पलिंग ले रहे हो, that is what is the chorionic villus sampling done in the first trimester, again to detect chromosomal abnormalities. And lastly, what is this? Very good. So this was a previous year question which came, the same image, and this is what is called as chordocentesis. Why? Because you are collecting a blood sample from where? From the umbilical cord. So it is known as chordocentesis. It will also help you detect any chromosomal abnormalities. Okay? So that's the important funda. Now, in all these three investigations, there is a risk of abortion in the patient. All of these are invasive techniques. Okay? Yes, they would be done. They are the best techniques. They are the gold standard techniques to detect any chromosomal abnormality. But abhi apna problem chromosomal abnormality hai kya? Nahi hai. What is our problem? Our problem is to rule out these anatomical defects. So now for anatomical defect, we will go for a non-invasive investigation. It is the investigation of choice to detect any anatomical defect in the fetus, which is done in the second trimester, and that is a level 2 scan. That is what is called as a level 2 scan. Level 2 scan is the ultrasound performed during the second trimester. What is the best time to perform it? The best time to perform it is 18 to 22 weeks, and that has been asked again. कब perform करते हो? तुम बोलोगे 16 हफ्ते पे, तो wait कर लो ना भाई दो. So 18 to 22 weeks pe in this patient will go for a level 2 scan. Please remember, that's most important. Okay. And level 2 scan is the investigation of choice. As I've told you, yahan pe likh raha hu main. Level 2 scan, as it is a non-invasive procedure. Okay, level 2 scan, as it is a non-invasive procedure, it is considered as the investigation of choice to detect what? To detect anatomical defects. No issues with this, anybody? I hope this is clear with everyone now. कोई दिक्कत नहीं आएगी. Moving further now. First, amniocentesis is not done. Amniocentesis का time ही अलग है. See, chorionic villus sampling is done in 10 to 13 weeks period of gestation, whereas amniocentesis is done to detect chromosomal abnormalities, but in the second trimester. It is usually done around 16 to 20 weeks. 15 से भी याद रख सकते हो. But the best time is 16 to 20 weeks में करते हैं amniocentesis. That is also an important thing to remember. No issues with this. Timelines are important. ठीक है? Then what are these? These are some anatomical defects that we have. And what are these defects called as? These are called as Mullerian defects. That means a patient from ops I'm going to gynae. Okay. So here we are talking about Mullerian defects. That is the anatomical defects in the female now. Okay, not about the child. So if I'm talking about Mullerian defects, that means usually, I hope all of you are quite aware, the female internal genitalia, they develop from which duct? They develop from the Mullerian duct, also known as the paramesonephric duct. Whereas male genitalia develop from Wolffian duct, also known as the mesonephric duct. Okay, that's important. So this Mullerian duct during development in the fetus, क्या हुआ? It did not develop properly. So क्या हो सकता है? Like there is one Mullerian duct on the right side, other Mullerian duct on the left side. Okay, it fused in the lower part, but it failed to fuse in the upper part. Upper part में it did not fuse properly. Okay, or second, it completely fused, but क्या हो गया? Just a minute. It completely fused together, but at the fusion it formed a septum. ठीक है, सेकेंड पार्ट में मैं बोल रहा हूँ लोअर पार्ट में फ्यूज है, अपर पार्ट में फ्यूज नहीं है. तीसरे पार्ट में मैं बता रहा हूँ कुछ फ्यूज नहीं हुआ है ऑलमोस्ट, ओनली द वजाइना इज फ्यूज, नॉट द सर्विक्स इज फ्यूज, नॉट द यूट्रस इज फ्यूज. ठीक है, या फिर एक साइड की ही मुलेरियन डक्ट डेवलप हुई है, द अदर साइड मुलेरियन डक्ट डिड नॉट डेवलप. ठीक है, so all of these can be the possibilities in Mullerian duct defects. So let's see that. What is this investigation first of all? जो दिख रहा है इमेज में, यही पूछा गया था क्वेश्चन में. Very good. So this is the first line investigation to detect any Mullerian defect. So the first line investigation to detect any Mullerian defect is a HSG, when a dye is injected into the uterus of this patient and an X-ray is taken. That is what is called as the hysterosalpingography. Hysterouterus salpingography picture. ठीक है? So what is seen on this HSG scan? Both of these are quite similar. Okay, both of these would be quite similar for you.
Yeah,
यहाँ पे in this you can see, you need to see. This is what is the most common Mullerian defect. What is the most common Mullerian defect? It is the septate uterus. The most common Mullerian defect. Anybody whose mic is on, please. So the most common Mullerian defect is known as the septate uterus. ठीक है? और septate uterus.
Mute your mic, please.
What is this? Anybody?
अब बुखार आया ना बोल दिया अगर यार बाहर नहीं
bicornuate uterus. Now how to differentiate it? So please remember HSG is not conclusive. So the final investigation नहीं है. So here you are not very sure that it is a septate uterus or a bicornuate uterus. But there are only two parameters on which you can actually differentiate both of these conditions. First क्या है? You need to see this is one cornu, this is another cornu. ठीक है? Cornu is nothing but horn. So you need to see the angle between the two cornu. If the angle between the two cornu is an acute angle, that means usually less than 70 degrees. Okay? Or if the distance between the two horns, the distance between the two horns is less than 4 centimeter, then this is more likely to be a septate uterus. ठीक है? Whereas on the other hand, अगर the distance between the two horns is more than 4 centimeter, or if the angle between the two horns is an obtuse angle, usually more than 105 degree, then it is considered to be a bicornuate uterus. But for further confirmation whether it is a septate or a bicornuate uterus, what is to be done? What is the investigation of choice? Investigation of choice to detect Mullerian defect. जल्दी से बता दो. Hysteroscopy पे तुम्हें septum तो दिख जाएगी. So if it is a septate uterus, then you will be able to make it out. But if it is a bicornuate, then तो इसीलिए investigation of choice अगर पूछा जाता है Mullerian defects के लिए, along with hysteroscopy, always go for laparoscopy also, because one camera you will insert in the uterus, one camera you will insert in the abdominal cavity, and you will see the uterus from above. ठीक है, तो दोनों तरफ से अगर तुम इन्वेस्टिगेट करोगे then it will be much easier for you to pick up any defect as such. ठीक है, so hysteroscopy plus laparoscopy is the best answer. If that is not an option, single best मारना है तो क्या मार्क करोगे? Then you need to mark it as not hysteroscopy but laparoscopy. ठीक है, because hysteroscopy will only tell you about one anatomical defect and that is septate. But बाकी सब के सब किस पे दिख जाएंगे तुम्हें? Laparoscopy. Therefore, the second best answer should be laparoscopy. No issues with this, anybody? Clear? Now, what is this? Here you can see only one horn of the uterus is formed. So this is what is called as a unicornuate uterus. Okay? And lastly, what is this? Here you can see the uterus is separate, the cervix is separate, only the vagina is together. So this is what is called as a uterine didelphys. This is what is known as uterine didelphys. No issues till anybody? Now if I talk about this cannula which came in your examination earlier. So this cannula is used to inject the dye into the genitalia of this female during a HSG scan. So this cannula का नाम क्या होता है? So this is what is known as a Leach-Wilkinson cannula. So this is what is known as a Leach-Wilkinson cannula. It is used to inject a dye during HSG. I hope there is no issues now. ठीक है, तो याद रख लो ये बात. If a patient is having one pregnancy loss or one abortion and she was diagnosed to be a case of septate uterus, will you treat her? By which mechanism you will treat her? Please tell me which method, sir. If a patient was having a septate uterus, she had one abortion, what would be the treatment? So please remember